Hello, welcome to Pathagonia. This is Jay. Today we're going to talk about what's a type and screen and why is it so important. What is a type and screen? Basically, that's the question of what is the patient's ABO blood group and are they Rh positive or negative? So how we find this out is we do a front type and a back type. So for the front type, you'll see the front type includes the first three on the left as well as a control. So the first three uses the patient's own red blood cells. And then you add anti-A serum, anti-B serum, and anti-D serum. So I talked about Rh and then I talked about D. So Rh has multiple antigens and D is the one we test for during the type. Okay, so if it's positive, then the red blood cells will agglutinate towards the middle of the tube. So for A and B, there's no reaction on the patient's red blood cells. So that indicates that they don't have A or B antigen. So this consists with O. But you see some reactivity in the D tube. So this is O positive. And then you have your control. And then the last two on the right is known as a back type. And this is kind of like a control just to verify this patient is O pos. For a patient who's O, they will have preformed antibodies against A and B. So back type is patient's plasma instead of the red blood cells. So the patient's plasma with known reagent A and reagent B cells. So if the patient's plasma if the patient is O, then they should have anti-A and anti-B. And that's consistent with what we have here. The patient's anti-A and anti-B in the plasma reacts with the reagent A and B cells. That's why you have agglutination in the middle of the tube. So this is consistent with O pos. Okay, we do that. We found out the patient who's getting surgery. We find out they're O pos. What is the screen? Basically, it asks the question and answers the question, does patient have antibodies against any of the most common red blood cell antigens? And there are a lot of antigens besides ABO and D. So what is a screen? So it depends on your institution. At our institution, we use 3 known reagent cells. And these cells, we know what antigens they express. And then we put the patient's own plasma into the tubes. And if there's no agglutination, then this is great. However, and it will be easy to issue blood and you're good to go. But what if the screen is positive? Remember that agglutination? What if there's agglutination? You can either have it for 1 tube, 2 tubes, or 3 tubes. If it's 3 tubes, it might suggest there might be some either antibody to a very common antigen or that the patient has an autoantibody. If it's positive, either 1, 2, or 3 tubes are positive, then we got to proceed to the antibody screen. So this is more extensive. It's more work, it takes more time. Instead of the 3 tubes, we use more tubes. We use more reagent red blood cells that we know what antigens they have, as well as an auto control. And based on the process of elimination, based on what reagent red blood cells it reacts to and which ones it doesn't, you can deduce what antibody the patient has. One of my senior residents, who's now staff, had kind of likened it to Sudoku. So this is just a table format of what antigens each cell, reagent red blood cells have, and if it's reactive or not. So now what? You found out what antibody the patient has. So now in our blood bank, if the surgeon orders for blood, we will give the patient donor blood that will be negative for the antigen which the patient has an antibody against. I know that sounds confusing, but we'll go into further detail. For instance, if a patient has an antibody against big K antigen, then we will give donor blood that does not have big K antigen. So this is your patient's blood and plasma. They have, as we found out through the antibody screen and then the antibody panel, they have antibodies against big K. And in the blood bank, you have donor 1 who doesn't have the big K antigen, and you have donor 2 who does have the big K antigen. So you would not want to give donor 2 blood to the patient, otherwise the antibodies can bind, and that can lead to hemolysis, can lead to renal failure, can lead to DIC, can lead to death. I mean, these are very rare instances, but it can happen, and you want to give donor number 1 blood to the patient. So, kind of on a tangent, but on a related note, why should you order a type&screen before the day of surgery? So, say the patient has an OR scheduled for 8 a.m. and you forgot to order a type&screen during the pre-admission encounter. So you draw one at 6:30 the same day. And usually it'll be quick because the antibody screen will be negative and you don't have to do the whole panel, and surgery will be good to go. And if the surgeon needs blood, then we'll be quickly able to issue blood. However, if the antibody screen is positive, then you saw what we had to do with the extended antibody panel, which can take several hours sometimes. Thus, the surgery is delayed and the patient, who's already probably worrying about the surgery, has to wait longer. Plus, you don't want to risk giving patient blood that they have an antibody to for aforementioned reasons. So that was a quick overview of what a type&screen is. Thank you. If you want to see more videos like these, please subscribe to Pathagonia. Bye.